Thank you, Mr. Chairman. Good afternoon. I'd like to thank the scientific committee for giving me the kind invitation. And this is my disclosure. I think that we can agree that gastric cancer can be considered a systemic disease. And I think that most of the patients present a diagnosis with an advanced stage. And even after radical resection, most of the patients will recur. About 60% of them will recur in spite of even adjuvant treatment. So I think for a systemic disease, we need a systemic treatment. And the chemotherapy has been a cornerstone of treatment for a long time. And we know that chemotherapy is able to double survival, improve quality of life in comparison with best supportive care in first line. And we know also that it should be given at the demonstration of a metastatic disease. And chemotherapy may obtain a high number of response rate, but really they are short-lasting. And in spite of these premises, however, we have a really small improvement in survival because after more or less 20 years of clinical research, no proposed regimens were able to overcome the 1-year survival wall. So a better knowledge of biology of gastric cancer and the potential development of targets and the drugs able to target them probably open new rooms for the treatment of gastric cancer. And my talk will be focused on HER2 inhibition and angiogenesis inhibition. HER2 is positive in more or less 20% of the patient, and this is quite common independent of regions where the HER2 has been assessed. And generally, it may be different according to histology, is more frequent in intestinal type, and according to tumor location, is less expressed in distal stomachs, there is higher in gastroesophageal junction. However, in spite of this data, this is a debated issue if HER2 is prognostic, because in this meta-analysis, there's a large number of patients, there was not able to draw any conclusion about the prognostic role of HER2. However, a phase 3 trial run in the past, and Trastuzumab, after has been demonstrated active and effective in breast cancer, was tested in gastric cancer, and you know very well these trials, obviously. This was a comparison with the chemotherapy plus or minus Trastuzumab. And a well-defined data was that positivity for HER2 was no more than 20-22%. And the result was clearly impressive. For the first time, there was an improvement in response rate, an improvement in progression-free survival, and an improvement in overall survival. And this improvement in overall survival was really clear and significant when you assess patients with immunohistochemistry 3+ or immunohistochemistry 2+ FISH positive, where the median survival reached 16 months. It was for the first time that in gastric cancer tumors, it's obviously in a subgroup of gastric cancer tumors, we were able to reach this median survival. And it is really relevant because for the first time, the 1-year wall was broken down. But in spite of these favorable, positive results, we have to keep in our mind that this is effective only in a small group of the patient, between 20%, about 1/5 of all gastric cancer patients. And even in this group of the patient, only just more or less half of the patient may benefit from this approach. And obviously, the positivity of HER2, we can increase the number of the patients. There is no methodological problem in assessment of HER2. But we can improve the results in HER2-positive tumors, probably by using 2 different strategies, by TDM1 or by overcoming the resistance of Trastuzumab. And we can use probably HER2 receptor as a Trojan horse in order to internalize chemotherapy by TDM1. TDM1 is a monoclonal antibody, Trastuzumab, conjugated with an anti-cancer agent, and by internalization was able to kill the cells, probably saving normal cells. But we have to wait for the result of this randomized trial comparing TDM1 to different doses with a combination of Paclitaxel, docetaxel in the second line. A more interesting approach could be how to overcome the resistance to Trastuzumab, because we know, even in breast cancer, that Trastuzumab is not effective in blocking the effect of the dimerization, heterodimerization of HER2, HER3. And probably in gastric cancer, this kind of heterodimerization is particularly frequent, precluding probably the effectiveness of Trastuzumab. And if you look at the incidence of overexpression in gastric cancer, this is not a secondary problem in order to prevent resistance to Trastuzumab. And Pertuzumab may be an answer to this question because it's able to inhibit not only the dimerization HER2, HER1, HER2, HER2, but even HER2, HER3. And the phase 3 Jacob trial, probably exploring this hypothesis, probably can answer the question if Trastuzumab plus Pertuzumab may be effective in a subset of HER2 positive tumors and not responding to Trastuzumab alone. And what about Lapatinib? Lapatinib is a TKI inhibitor of HER2, is by blocking the intracellular part of a receptor, is blocking the downstream signaling pathways. And it could be in reality of interest because in gastric cancer, much more than breast cancer, the truncated HER2 receptor, losing the extracellular part of the receptor, are particularly frequent. About 70% of the tumors present this particular receptor, and Lapatinib is able to block even this modified receptor. Unfortunately, in spite of this hypothetical premises, in reality, negative trial in phase 1, in phase 3 trial in first line, Lapatinib combined with oxaliplatin and capecitabine was not able to improve. In the intention to treat population, all the population, overall survival was the primary endpoint, it was not met. But if you look at the subgroup of the patient, this was not a pre-planned analysis, it was quite interesting that it was positive for immunohistochemistry 3+. But it was completely negative in an Asia population in second line. So probably we have not a clear reason why Lapatinib doesn't work by blocking in gastric cancer HER2, but probably there is several molecular reasons, probably MET, PI3K, can explain these negative results. The other potential target was angiogenesis, and I will focus on Bevacizumab as blocking as inhibitors of VEGF alpha and the VEGF receptor 2 by Ramucirumab. Both are well known that they are predictive prognostic factor in terms of overexpression. Unfortunately, HAVAGAS trial was a large randomized trial comparison chemotherapy plasma was not positive. In reality, there was a trend, at least for PFS, significant advantage in terms of PFS and the response rate, but not in terms of survival. And what about the inhibition of VEGF receptor 2? We have 2 randomized trials in second line gastric cancer comparing Ramucirumab versus placebo and Ramucirumab plus Paclitaxel versus Paclitaxel. I would like to underline that most of these patients, above all in Ramucirumab Paclitaxel trial, presented the unfavorable characteristics. Mainly, most of these patients presented the peritoneal carcinomatosis. Peritoneal carcinomatosis was a negative predictor of response or the advantage for second-line treatment, even if all of the patients, the majority of them, probably all of them, presented a good general condition with an echo performance status of 0.1. And both trials were able to demonstrate an advantage in PFS and in overall survival for Ramucirumab. And while Ramucirumab alone was not able to determine any response rate. It was interesting that in combination with the Paclitaxel increased the response rate about 10% of Paclitaxel. So probably is not able to determine a response rate when given alone. It could have a synergistic effect with the Paclitaxel. Paclitaxel may have an effect as antiangiogenic therapy, so may be the sum of the two actions. And to support the role of inhibition of VEGFR receptor 2, probably is given the results in this phase 3 trial in third line or more in Chinese population, where Apatinib was able to demonstrate an advantage, as well as regorafenib in patient refractory to chemotherapy was presented at ASCO in terms of PFS was able to demonstrate an improvement. In reality, it's a small improvement, but there was. And how Ramucirumab is placed in terms of other treatment options in second line for gastric cancer. And if you look at the Ramucirumab-Paclitaxel combination, there is a median survival is more or less the double or other anti-cancer agents, and even immunotherapies compare well with the chemotherapy. And even in terms of toxicity, apart from hypertension, this is not a particularly different respect of placebo. There is obviously an increase, but not in comparison with the chemotherapy or Paclitaxel alone. So the toxicity profile is quite safe and manageable even for frail patients as advanced gastric cancer patient. And some concern may arise about the role of Ramucirumab from the result of, in first line of this phase 2 randomized trial, comparing Ramucirumab plus Folfox versus Folfox alone. But because the progression-free survival was not influenced by the addiction of Ramucirumab to chemotherapy. But if you look at the patient characteristic, about half of these patients were esophageal cancer. And if you look at an analysis, an exploratory analysis because it was not replanned, and according to tumor location, esophageal and gastric or gastroesophageal junction, you can see that there is a negative result for esophageal and a positive for gastric. This is not relevant because there is running a phase 3 trials in first line, but I think it's important because it suggests that probably esophageal and gastric cancer are two different diseases, and probably we have to pay attention when they combine in the same trials. So, in conclusion, we can say that targeting HER2 may have a role and a clinical impact. Yes, I think so, but I think there's general agreement that the patient with HER2 positive tumor should receive Trastuzumab. I hope that in the future we can improve the result by adding Trastuzumab or TDM1, and probably we have moved from advanced disease to neoadjuvant treatment as demonstrated in the previous presentation. And what about the targeting, not angiogenesis, but at least now VEGFR2? I'm really grateful to Florian because it makes my conclusion easier, because this algorithm is, I think, I agree with the algorithm, and I think that Paclitaxel and Ramucirumab can be an option for second line for patients with a good performance status, and probably even we need a response rate or a tumor regression in order to improve the symptoms. And we can deliver even Ramucirumab as monotherapy because it's as effective, is manageable in terms of toxicity, and probably prolong and survival. And probably there is most of these patients, however, will present with general conditions, with worsening of general conditions, so they can receive only best supportive care. But in my mind, I think that Ramucirumab may be an option for second line in advanced gastric cancer tumors. Thank you very much for your attention.